Thank you, thank you, Tiffany. Can you hear me okay?
Yes.
Great, great. Good afternoon or good morning, everyone. I'm really happy to be with you today. As Tiffany said, my name is Marcus Allen. I'm the Children and Youth with Special Healthcare Needs Program Director for VDH. I recently lost my sickle cell coordinator, who some of you may know, Shamari Cromartie, and I believe she's on the call actually today. But I'm very happy to be here to talk to you all. I value the work that you do, and I'm just excited to be here. So this is just an outline of what we're going to talk about today. So I'm just going to talk very briefly about what sickle cell disease is, as I know that Dr. Davidson is going to get into more of the clinical specifics. And then I'm going to share several other things about our program and the work we do here at VDH. So as some of you may know, sickle cell disease is one of the most commonly inherited blood disorders. So it's inherited when a child receives two abnormal genes, one from each parent, that code for the hemoglobin gene. So as you may know, and as you see in the picture, normal red blood cells are generally round, plump, and flexible. Whereas with sickle cell disease, the red blood cells are rigid, sticky, and not flexible, and that causes them to stick in blood vessel walls. So this can stop the flow of blood, which can prevent the flow of oxygen from reaching nearby tissues. And as I'm sure you may know, lack of oxygen can cause sudden severe pain and in some instances, organ damage. So we know that red blood cells travel throughout the whole body. So as I was mentioning, every organ can be affected by sickle cell disease. It's a lifelong condition, and it reduces life expectancy. And it also is more than just costly to the individual. It is very costly to the individual, but it's also costly when it comes to providing care. The last thing I want to note, and something I like to talk about, because there can often be a lot of confusion, sickle cell disease is not the same thing as sickle cell trait. People who are carriers of the trait will never have sickle cell disease. So this just a slide about some data and statistics. And as you can see, sickle cell disease affects millions of people worldwide. And most of the people that it affects are those whose ancestors come from sub-Saharan Africa and Spanish-speaking regions in the Western Hemisphere. So also Saudi Arabia, India, and Mediterranean countries. Currently, there is no data system in the United States to determine the exact number of people living with sickle cell disease, but it's estimated to affect about 100,000 individuals in our country. I will note that the Centers for Disease Control is working on determining the number of people in the country with sickle cell disease. And it's a project that you can find more information on about online, but we still do not have an exact number. So in our state, we have approximately 75 babies born each year with sickle cell disease, and they are identified through newborn screening. As I mentioned before, the number of people in Virginia with sickle cell disease is unknown, but we do know through our pediatric and clinical partnerships across the state, we do know that we roughly are aware of 1,800 clients, roughly 1,800 clients through that partnership. I did also want to mention that detailed information about our newborn screening program and newborn screening data is available on the website if anyone has an interest in that information. So just a little bit more about the dry blood spot program. So sickle cell is part of the panel of 30 plus conditions. So our sickle cell coordinator, when there's a child that is identified on a newborn screen as having sickle cell or has been screened positive for sickle cell, our sickle cell coordinator will reach out to the physician on record. And then that person will notify that physician, usually a pediatrician, and ask that the test be repeated. Once the test is repeated and confirmed, then we refer the child directly to one of our pediatric sickle cell providers. And we have several across the state. And this referral process is in the Virginia Administrative Code. And it lays out how we will follow up on children with sickle cell disease. And I will say, I think that newborn screening is one of the greatest accomplishments of the 20th century. I believe that newborn screening has, well, not believe, I know newborn screening has saved countless lives, not just for people with living with sickle cell disease, but other conditions as well. So it's just been a wonderful thing. And I think it's very good that VDH is lucky enough to have relationships with providers across the state, such as Dr. Davidson, who will speak later. So program structure, we have the Virginia Sickle Cell Awareness Program, which we call VASCAP. We have a pediatric comprehensive sickle cell program, an adult comprehensive sickle cell program, and our new sickle cell disease registry. So VASCAP, all of our programs are written into the Virginia Administrative Code. So the purpose of VASCAP, that's our promotional arm. So it promotes awareness of sickle cell disease. In the past, we have done radio ads about sickle cell disease. I'm working on starting that this week or next week to promote awareness of sickle cell disease. VDH does partner with our local health districts who will screen existing clients that they have, mostly through their family planning clinics, some through maternity clinics. And what they will do is they will educate the client on what they find on the screening. So they will provide some general counseling about sickle cell if we find people with sickle cell trait and of course, sickle cell disease. So I mentioned about the public awareness campaigns, but we've also published resources such as pamphlets that my previous employee created, some buttons that she created to wear that promote sickle cell disease. And interestingly, one of my favorite things, some church fans. I will say we've had a huge demand for supplies this month, so much so that we're almost out. But if anybody's interested in how they can print some supplies, they are welcome to email me. Like I said earlier, we've partnered with Radio One to air awareness ads on local urban radio stations, and I'm in the process of getting that done again with Radio One. So the Pediatric Comprehensive Sickle Cell Clinic Network, as I mentioned before, this network is in the Virginia Administrative Code. One of the primary things is entry into care. That's paramount. Out of anything that the sickle cell coordinator does, she or he, the most important thing is entry into care. When a child is confirmed on a newborn screen, we will immediately notify the pediatrician, like I mentioned earlier, but also the sickle cell center in their region. And the sickle cell center will immediately reach out to that family and offer services to them. Now, our services are not mandatory, but I do think it's rare that families will refuse to have their child cared for at a sickle cell center. So I mentioned the centers. So the 5 centers are at Virginia Commonwealth University, University of Virginia, Children's Hospital of the King's Daughters, Physician Specialists of Virginia, and Carilion. So in addition to entry into care, coordination of care is an essential function. So at all of our partners, or through all of our partners, they're able not only to care for the young person or the child who has sickle cell disease, just to focus on the disease, but they also are very good and very well-established health systems. So if a young person is having other issues as a result of their disease, they can refer them to them. So when I'm talking about other issues, I'm talking about neurology. I'm talking about if they're having problems with their kidney or any other type of issues. Our centers are a place where families can go and receive all the services they need to make sure that that young person has the best care that they can get in their region. The other thing that's very important is transition to adulthood. They emphasize the importance of transition. We have done a lot of work in this country with some of these rare diseases to help children and to improve their health and their well-being. One of the things that I feel we struggle on is that next level. So when we've gotten them really healthy through our excellent pediatric centers across the state, there have been struggles to find adult providers that will care for them, like Dr. Davidson. So this is something that is really emphasized by our centers. They start working with families and talking about transition somewhere around 14, 15. Some will talk about it much earlier because they want families to understand that you really need to have an interest and care about where your care will be provided once the young person ages out of peds. So this next slide is talking about our adult comprehensive sickle cell clinic network. We are very proud of this new accomplishment. The adult network is new. It started under the previous governor and General Assembly, and they were able to appropriate funds. I will say that one of the wonderful things about sickle cell disease in the state of Virginia is bipartisan. Whenever we have talked about sickle cell disease and whenever we have visited the General Assembly, it has been pretty much overwhelmingly bipartisan. Everybody seems to understand the importance of helping people who are suffering with sickle cell disease. So our adult network has only been up for a couple of years. It closely mirrors our pediatric network in regard to location, and then also the importance of care coordination and transition. Those are all very, very important. So our regulations went into effect in 2021, and we issued RFPs or requests for proposals in 2021. So our current partners include UVA, VCU, Carilion, and Inova. We are working with Eastern Virginia Medical School to confirm an agreement with them for the Tidewater area. So a couple of other things I want to talk about. In the 2024 General Assembly, there were two important bills that I want to briefly bring up when it comes to sickle cell. So House Bill 252 is the statewide sickle cell registry. So what that does is it establishes a state sickle cell disease registry in Virginia. So VDH is charged with creating that registry. We're in the process now of doing so. The House Bill 252 ended up requiring that physicians and care of people with sickle cell disease, they will be required to report to the registry once it's up and running. And we anticipate the funding just went into effect in July, on July 1st. So, as you may imagine, to create such a database, it takes time. So we anticipate once we hire our epidemiologist and our new sickle cell coordinator, we anticipate the registry to be up and fully functional sometime around June or July of 2025. And then we will be doing outreach first, of course, with our sickle cell centers. We'll be partnering with them initially to test the registry to make sure it's functioning. And then we'll be reaching out to them to work with them to enter all of their information. One thing I will say is there is a requirement that the information be entered into our database once it's developed, but there is an opt-out clause in the law. But one of the things we are hoping to do is to help people to understand, people living with sickle cell disease. One of the ways we can keep advocating for them is, especially our partners, is knowing more information about them, being able to document how many people actually live in our state with sickle cell disease. It's really hard. It can be hard to get funding when we don't have the statistics that we need. So not only do we want to document how many people in our country are living with in our state are living with sickle cell disease, we also want to know more about their morbidity and mortality. And when we can learn more about their morbidity and mortality, we can work with our partners to formulate strategies to improve health outcomes. So that's the purpose of the registry. And then I also want to mention House Bill 255. That is adult wellness screening. This is not mandatory as far as whether or not people will be screened. It's asking for providers it's encouraging providers to test their clients for sickle cell trait and or sickle cell disease, specifically those of reproductive age. And like I said, it is a voluntary program. So plans for the future, we want to continue to develop the adult clinic program. As I mentioned before, our goal is to make sure that everybody in the state has access to care that's living with sickle cell disease. A big part of the way that we do that is with the infrastructure bill that we had for the adult program. So having an adult program that we require to partner with the pediatric programs in the region. We know that when the adult providers partner with the pediatric providers and work hard to build relationships with them and the pediatric clients, it is more likely that families will transition to adult care because they already have a trusting relationship and they've become familiar with the adult provider in their region. So I'm in the process of replacing our recent vacant statewide sickle cell coordinator. That's a position that's going to be some big shoes to fill, as the person who was in the job, Shamari, did an amazing job as coordinator. So I hope to have that position filled sometime in October, but no later than November. We want to launch the registry, as I mentioned, sometime around June, July of next year. And we will be reaching out to all of our centers. We will be meeting with them in the coming months to gather, to share our plan with them regarding the registry and to get their feedback about our plan. So we are working to hire registry staff now for the statewide sickle cell registry. The first position we're hiring is the epidemiologist, and this is in addition to the statewide sickle cell coordinator. We are hiring the epidemiologist because we believe that position is a priority. And once we hire that person, they will begin immediately to create the registry. And then they will do this in partnership with our division for population health data and in partnership with our sickle cell coordinator. And then after when we get close to getting the database up and running, we do plan to hire a person who will be the registry coordinator, who will work with the epidemiologist on day-to-day work that's involved in the registry. So that person will likely be traveling across the state to provide education and technical assistance to providers when it comes to entering the data into the website. And then they will also work with the epidemiologists here in central office to develop plans on how we will use the data and how we will work with our partners to improve the health of the people we get to serve. So last, as I was saying earlier, we're going to use the registry data to help inform our decision-making on the key public health aims for sickle cell disease. So that's all I have for my slides. So I'm going to stop sharing now. And then I am going to turn it over to my friend, Dr. Davidson.
Thanks, Marcus. Can you hear me?
Yes, I can hear you.
All right, let me see about this sharing of slides. Hold on a second. All right, can you guys see that? Yes, hopefully. All right.
Yes, I see it.
Okay, thanks. Well, thank you so much to everybody for being here today. I'm really excited to speak with you about sickle cell disease and pregnancy. Please stop me or ask questions in the chat if something doesn't make sense. I know we have kind of a broad audience, so hopefully this isn't too technical, but I wanted to talk about some issues that I think are important for our patients to have successful pregnancies with sickle cell disease. So first, a little introduction about sickle cell disease, and then we'll launch into a review of both maternal and fetal risks of a pregnancy that's complicated by sickle cell disease. We'll next talk about the importance of preconception counseling for our patients. We'll talk about issues during the pregnancy or antenatal management. And then lastly, we'll talk about what we need to do around the time of delivery and postpartum care for women with sickle cell disease. So as Marcus mentioned, sickle cell disease is the most common inherited blood disorder in the United States. And we don't know exactly, but we estimate that it affects about 100,000 Americans. And most of these are African American patients, but it can affect other ethnic groups as well, including Hispanic Americans. And millions more people worldwide have sickle cell disease, the majority of whom live in sub-Saharan Africa. In the early 1970s, the median life expectancy of someone with sickle cell disease in the United States was only 14 years. But due to some improvements in supportive care and disease-modifying therapies, a growing number of people with sickle cell disease now survive into their reproductive years. And so we're seeing a lot more pregnancies now in patients with sickle cell disease. And even though we have had these improvements, the median life expectancy of a person living with sickle cell disease in the US is still only 40 to 60 years. So it lags 20 to 30 years behind a person who doesn't have sickle cell disease. So we still have a lot of progress that needs to be made. And although in the past, 50 years or so ago, sickle cell disease people were discouraged from becoming pregnant, but now we know that most of those women should be supported if they choose to pursue a pregnancy. But it's important that both they and their providers are aware of the unique maternal and fetal challenges that are associated with having a pregnancy with sickle cell. So sickle cell disease is due to a specific genetic mutation that occurs in what is called the beta globin gene. And this leads to an amino acid substitution in that protein of beta globin. And beta globin is part of hemoglobin, which is the protein that is inside of our red blood cells that delivers oxygen. And unlike normal hemoglobin, this abnormal hemoglobin, which we call hemoglobin S, polymerizes or becomes rigid when it is deoxygenated. So when there's low oxygen, that hemoglobin forms these polymers that causes the red cell that's normally round and flexible to take on this sickled shape. And you can see here in the cartoon, it looks kind of like a sickle, which is an old farming instrument. And these sickled red blood cells get stuck in the blood vessels, and this leads to what we call vaso-occlusive complications. The most common one that we all probably know about is a pain crisis. Other things like acute chest syndrome are also common in people with sickle cell disease. And they also have something called hemolytic anemia. So you can see in that bottom right picture, those red blood cells are being broken down. Those cells are rigid and not flexible, and so they tend to get destroyed. And this causes a chronic anemia and other complications as well for our patients. So although sickle cell disease is due to just one mutation in one single gene, it causes a number of acute and chronic problems that basically affect every organ system in the body, including the brain, the lungs, the heart, the kidneys, you name it. This picture kind of shows the most common things that we see in sickle cell disease. And in pregnancy, not only are women with sickle cell disease at increased risk for problems related to their underlying blood disorder, but they are also at higher risk of a number of pregnancy-related complications. And unfortunately, there are also increased risks to the fetus if the woman is affected by sickle cell disease. So sickle cell disease affects multiple organ systems and is associated with an increased risk, sorry, I'm on call, of sickle cell disease-related morbidity during pregnancy. So vaso-occlusive pain crisis, which is the most common thing that we see, is also the most common maternal sickle cell disease complication, occurring in over 50% of pregnancies affected by sickle cell disease. Things like a pain crisis or acute chest syndrome are at the highest risk in the third trimester and up to 1 week postpartum. So this is a particularly risky time for our patients. We know that both pregnancy and sickle cell disease both individually carry an increased risk for blood clots, and pregnancy in people with sickle cell disease may further enhance the prothrombotic effect of the underlying disease. And so both of these situations are increased risk for clot in our patients. There's a 2-fold increased risk of a VTE, so something like a deep vein thrombosis or a pulmonary embolism. We see these unfortunately commonly in people with sickle cell disease who are pregnant. And it's also an increased risk of stroke, on the order of 10 to 22-fold increased risk of stroke. And as you probably know, the postpartum time period is an even higher risk for thrombosis. So that is also a challenging time for our patients. There are a number of changes, both mechanical and immune, that occur during pregnancy that contribute to an increased risk of certain infections. In pregnant people with sickle cell disease, they already have a baseline increased risk of certain infections, including respiratory and urinary tract infections. And so this is a common problem. We see increased rates of pneumonia, sepsis, asymptomatic bacteriuria, or urine that has bacteria in it, is common. An increased risk of GU infections like UTIs, pyelonephritis. These are common problems that our patients face. There's a 2 to 13-fold increased risk of severe infectious morbidity, including sepsis in pregnant women with sickle cell disease. Anemia is unfortunately another common problem. Many of us know that in pregnancy, the plasma volume increases about 40 to 50%. So most women increase their red cell mass by about 30% to compensate for that. But women with sickle cell disease often are not able to do that without transfusion. And so we know that up to 60% of our patients are going to need a blood transfusion during their pregnancy. And this can be complicated by something we call alloimmunization. So that means that a woman receives a blood transfusion and then develops antibodies or alloantibodies against antigens that are in those red blood cells. And the problem with that is that limits the availability of blood products when transfusion is needed. It also puts them at increased risk for a hemolytic transfusion reaction, which can be a very serious problem in sickle cell disease. So the hypertensive disorders of pregnancy, things like preeclampsia and eclampsia, are also more common in women with sickle cell disease. And we don't know exactly why this occurs, but it is probably due to a combination of things like endothelial dysfunction or damage, which is occurring in people with sickle cell disease, increased inflammation, and placental infarction. Unfortunately, we have a lot of gaps in our understanding of preeclampsia and its relationship to sickle cell disease, so a lot more research is warranted. But we know that up to 12% of pregnancies with sickle cell disease develop these hypertensive syndromes as compared to 4% of non-sickle cell disease pregnancies in the United States. I also want to point out that women with sickle cell disease often have lower blood pressures, or patients in general with sickle cell disease tend to run lower blood pressures at steady state compared with the general population. And so subsequently, pregnant women who have sickle cell disease may have blood pressures that are actually quite a bit higher than their normal baseline, but it could be within the normal range for the general population. And so early signs of preeclampsia may be missed in the sickle cell disease patient. So it's important to remember that they do have an increased risk of this complication. We also see an increased risk of kidney issues in pregnancy with sickle cell disease. So there are both anatomic and physiologic changes that occur during pregnancy that can affect the kidneys and the renal system. There was a recent analysis using data from the nationwide inpatient sample that found a 9-fold increased risk of acute kidney failure at the time of delivery in patients with sickle cell disease compared to those without. So a significant risk of kidney injury in our patients. We also know that pregnancy is associated with increased cardiopulmonary demands. There's an increase in cardiac output during pregnancy, and most pregnant women are able to accommodate this unless they have underlying cardiopulmonary disease. But our patients with sickle cell disease are at risk of having underlying cardiopulmonary disease, particularly something called pulmonary hypertension, where the pressures inside the lungs are higher. And this affects up to 11% of people with sickle cell disease and is associated with not just increased pregnancy morbidity, but also significant maternal mortality in pregnancy. So in addition to problems that the woman may face, her baby may also be at risk. There's increase in fetal growth restriction, both intrauterine growth restriction and small for gestational age. These are often the consequence in sickle cell disease pregnancies of what we call ureteroplacental insufficiency, but they may also be due to infections, alloimmunization, spontaneous preterm labor, and less often opioid exposure. It has been said that intrauterine growth restriction is nearly 5-fold higher in babies that are born to women with sickle cell disease versus those without sickle cell disease. So definitely something to keep in mind. Preterm delivery is also a risk for our patients and their babies. In women with sickle cell disease, this increased risk of preterm delivery is predominantly due to maternal indications for delivery and not spontaneous preterm labor, which is the opposite of what we see in the general population. And the risk of prematurity is about twice as high in these babies born to women with sickle cell disease versus those without. So I talked earlier about something called red cell alloimmunization, which is when a woman receives a transfusion and then develops alloantibodies. So this is not only a risk to the woman herself, but also to the baby. If the woman has developed antibodies that can cause hemolytic disease of the newborn, these patients are at risk of having a baby that is born severely anemic or even stillborn because of this issue. So that's a significant problem that needs to be investigated if there's concern for that. There's also a risk of neonatal abstinence syndrome, which is something that we see in women who take chronic opioids. The baby can be affected by this. We think that intermittent use of opioids may be associated with lower rates of this, but this is something to be aware of if the woman has required chronic opiate therapy to treat pain during the pregnancy. And then lastly, perinatal mortality. There's increased risk of fetal and neonatal deaths in pregnancies that are affected by sickle cell disease. And these rates vary widely depending upon the country and economic resources. But in economically advanced countries like the US, it's estimated that 1.6 to 2.9 perinatal deaths for every 1,000 deliveries. So increased risk to the fetus as well. So I wanted to go over briefly this study, which I think is very interesting. It was published last year, and it's a large cross-sectional study of pregnancy outcomes in sickle cell disease. These investigators used what's called the U.S. Centers for Disease Control and Prevention Severe Maternal Morbidity Index to the national inpatient sample. This is a nationally representative sample of hospitalizations in the United States. And their analysis covered admissions from 2012 to 2018. And they looked at over 5.4 million deliveries. And this was 3,900 deliveries in women with sickle cell disease. The majority of these, 84%, were African-American patients. And what they found was really striking. The maternal mortality rate with sickle cell disease was 26 times greater than in the control deliveries of non-Black pregnant people, and more than 10 times greater than deliveries among Black pregnant people. So a significant risk of not just morbidity, which I reviewed previously, but also of maternal death in pregnancies associated with sickle cell disease. The investigators also wanted to look at how racial disparities contributed to risk of severe maternal morbidity and other adverse outcomes. And they performed what they called an excess risk analysis, and they looked at different pregnancy complications among sickle cell disease deliveries attributable to racial disparities. And they estimated this thing called an ER, or excess risk. And compared to groups that did not have sickle cell disease, deliveries among women who had sickle cell disease had significantly higher odds of severe morbidity, and racial disparities explained on average nearly 29% of the increased risk in sickle cell disease delivery. So it's not just the underlying disease, but also racial disparities that are contributing to these adverse outcomes. And this table just kind of highlights several of those, but I wanted to draw your attention to the three that I highlighted in red there. Racial disparities accounted for almost 57% of the increased risk for acute kidney failure, nearly 50% of the risk for intrauterine fetal demise, and 42% of the increased risk for eclampsia. So we have a lot of work to do here, clearly. So next, I wanted to talk about how you would address a woman who is planning pregnancy. You have a patient with sickle cell disease. It's important that we have a reproductive life plan for our patients. And unfortunately, I think this is something that we probably don't do a very good job of, but it's important to address counseling to discuss the increased risk to both the mother and the fetus when you have a woman with sickle cell disease who's of reproductive age. So first, you want to confirm the diagnosis in the mother, make sure that you have the right diagnosis. Next, you want to test her partner for hemoglobinopathies. And the way that most of us would start with that would be getting a CBC and something called a hemoglobin electrophoresis. And I want to point out to you that people are at risk for having a baby with sickle cell disease, even if the partner doesn't have sickle cell trait. So if a partner has another beta globin mutation, like beta thalassemia trait or hemoglobin C trait, these are pregnancies that are still at risk of a baby being born with sickle cell disease. So it's not just women who have sickle cell disease and a partner with sickle cell trait. There are other potential combinations that can cause forms of sickle cell disease. So once you know the partner's testing results, you can review the likelihood of sickle cell disease in the fetus, and I'll show this on a subsequent slide. And then it's important to let people know that there are alternative reproductive options. I think this is something that we fail to do pretty regularly, but there are things that can be done to ensure that the baby does not have sickle cell disease. Things like pre-implantation genetic diagnosis with in vitro fertilization techniques can be used, and patients should be referred to reproductive endocrinology if that's something they're interested in. So in this picture, this kind of goes over how you would determine what the risk is to the baby. So on the left, we have a woman who's in red. That means she has sickle cell disease. So both of her genes have the hemoglobin S mutation. And then her partner has sickle cell trait. And so if these two people have a baby, the baby has a 50-50 chance of having sickle cell disease and the other 50% chance of having sickle cell trait. On the right, if both parents have sickle cell trait, they would have a 25% chance of having a baby affected by sickle cell disease, as shown on the right cartoon there. So you want to be sure to perform a pre-pregnancy health assessment. So we get baseline labs, as shown here. You want to focus on the patient's blood pressure, whether they have increased urine protein, because these are things that we would worry about during pregnancy as well. We have a pretty low threshold to get a baseline echocardiogram. We know that pulmonary hypertension is a significant risk for pregnancy morbidity and mortality. So any women who have cardiopulmonary symptoms like shortness of breath or chest pain, or if they have risk factors like they've had repeated episodes of acute chest or PE, you'd want to obtain an echo. And then additional testing as needed per guidelines. So medication management is an important part of preconception care, and we always counsel our patients and their partners about potential fetal and neonatal risks of maternal medications. Hydroxyurea, historically, this has been a medicine that we've always said we should not use during pregnancy. This is based really on animal studies where animals were given very high doses of hydroxyurea. This hasn't really borne out in human cases when there have been mothers who've had hydroxyurea exposure during pregnancy. But traditionally, we do stop hydroxyurea, and we usually recommend stopping it if you're going to 3 months before attempts at conception. However, if the patient has had a particularly rough course and the hydroxyurea is very beneficial, this would really be a shared decision-making conversation. Other medications that you should stop in a woman who's attempting pregnancy is medicines that are called iron chelators for iron overload, and then ACE inhibitors and ARBs should also be stopped due to fetal risks. We start patients on folic acid, 4 to 5 milligrams daily. Iron should really only be given to women if it's necessary. Many of our patients are iron overloaded, and so you would want to check their ferritin and determine their iron status before putting them on supplemental iron. And there are prenatal vitamins that don't contain iron if necessary. Analgesia, we usually use typical medicines that we use for sickle cell, including opioids if necessary, which they often are to treat pain, although we usually avoid NSAIDs due to risk to the fetus. And then making sure they're up to date on their vaccines and any other routine preconception care. All pregnancies in women with sickle cell disease should be considered high risk. And so here at UVA, we would refer to maternal fetal medicine, and I would recommend that if that is an option for you in your area. The risk of complication can vary depending on the specific type of sickle cell disease a patient has. The most severe type is what we call SS, or when they have 2 sickle mutations. The risks may be lower with other genotypes, but it can vary person to person. If there is desire to know the diagnosis of the baby during pregnancy, there are 3 ways we can do this. Chorionic villus sampling can be performed at 10 to 14 weeks of gestation. An amniocentesis can be performed as early as 15 to 16 weeks. And then you can also do maternal blood testing for the beta globin mutation, this cell-free fetal DNA in the maternal blood. That would be another option. In addition to seeing their obstetric provider on a regular basis, we also recommend that a patient with sickle cell disease see their hematologist or whoever takes care of them for their sickle cell disease on a monthly basis. We recommend a monthly CBC to screen for severe anemia. And then we also recommend checking a urine culture on a regular basis. Many experts recommend checking one monthly. We know that women with sickle cell disease are at increased risk of urinary tract infections, and screening and treatment of bacteriuria are indicated because even when asymptomatic during pregnancy, if there is bacteria present in the urine, this increases the risk of pyelonephritis and has also been associated with preterm birth and low birth weight infants. And so we recommend screening at least every trimester, but often on a monthly basis. Every patient should have a transfusion plan. I don't have time to go into all the details of transfusions. Unfortunately, we don't have a lot of good data to support what we should do regarding transfusions in pregnancy. There's not a lot of good evidence to just put everyone on a transfusion protocol. Some patients do end up on chronic transfusions, but if you do have a patient, they should have a specific plan with an indication for transfusion, a hemoglobin goal if you have one, and what type of transfusion they're going to be getting, whether it's just a simple transfusion or an exchange transfusion. We want to be mindful that patients are at increased risk for pain crisis, and so we should avoid anything that could precipitate a pain crisis when possible. That includes extreme temperatures, dehydration, overexertion. We tell all of our patients, pregnant or not, that fever is a medical emergency. They're at increased risk for infection, so that should be taken very seriously. And then again, updating vaccinations. While the patient is pregnant, if you haven't already done so, you should take a look at their medication list and make sure that they are not taking anything that would be contraindicated. Hydroxyurea, again, is often discontinued, although there are instances where we would consider leaving a patient on hydroxyurea if necessary. Other disease-modifying therapies that you might have heard of, there are 3 others, voxelotor, crizanlizumab, and L-glutamine. These are not well studied in pregnancy, so we typically stop those as well. We continue folic acid. Women with sickle cell disease are at increased risk for preeclampsia, as I've mentioned, so we tend to put them on low-dose aspirin starting at 12 weeks unless there's a contraindication. They're also at higher risk for clots. And so if they become hospitalized for some reason, like a pain crisis, or if they have specific high-risk features, we may put them on low molecular weight heparin for VTE prophylaxis. We also recommend that everyone have an individualized pain plan. I want to point out that women, will require pain medication pretty frequently during pregnancy for pain crisis, and opioids are appropriate to use if necessary. We also use acetaminophen. NSAIDs specifically are generally avoided because of increased fetal risks, especially if they're used for more than 48 hours, particularly after 30 weeks, but we tend to avoid these during pregnancy. Increased maternal surveillance of both blood pressure and urine protein is important. And although normal blood pressure ranges in pregnancies and thresholds for the diagnosis of preeclampsia have not been established for sickle cell disease, it's important that this be monitored carefully, as well as urine protein due to the increased risk for preeclampsia in pregnancy. Fetal surveillance, we also recommend increased fetal surveillance with serial ultrasounds for growth every 3 to 4 weeks, starting in the third trimester, and antepartum fetal heart rate testing starting around 32 weeks or sooner if indicated. The risk of stillbirth can be reduced, but not eliminated with these measures. So in terms of delivery, the mode of delivery really should be determined by obstetric indications. There's no reason that a patient with sickle cell disease has to, for example, have a C-section, although I will note that the rate of C-section in patients with sickle cell is quite significant in the US, around 38%. So many of our women with sickle cell disease will end up with a C-section. Unfortunately, we don't have a lot of good data to guide this information about when to deliver a patient or if they need to have a planned delivery, but many experts recommend a planned delivery around 37 weeks. And this is because we know that there's a risk of placental insufficiency, as the pregnancy progresses. And so many experts will go ahead and plan the delivery, right around 37 weeks for women with more severe forms of sickle cell disease. We also don't know what the hemoglobin goal should be for a vaginal delivery. We do know that for surgeries in general with sickle cell disease, we recommend a hemoglobin of 10. So if a woman's going to have a C-section, we try to make sure she has a hemoglobin around 10. Because so many women with sickle cell disease will end up with a C-section, it is reasonable to try to get their hemoglobin around 10 in the event that they will need a C-section, but there is no good data to support this for vaginal deliveries. We recommend adequate hydration, pain control, oxygen if needed, and then something called an incentive spirometer around the time of delivery. This will help reduce the risk of acute chest syndrome. For most of our women, we recommend VTE prophylaxis with low molecular weight heparin after a vaginal delivery or a C-section, and we usually continue this for 6 weeks postpartum due to the increased risk for DVT and PE in that time period. One thing that doesn't come up too often, but this is also a time that you might consider a cord blood harvest. If the baby does not have sickle cell disease and has only sickle cell trait, and there's a relative who has sickle cell disease, this might be something that you have organized if someone's planning a cord blood transplant. As with all women, we encourage breastfeeding. This is around the time that we're going to talk about when and if to resume certain medications. Hydroxyurea does get a little bit into the breast milk. It's very small amounts, and so it is not an absolute contraindication to breastfeeding, although many women prefer to hold off on resuming their hydroxyurea until they're done nursing. We also don't use iron chelators during this time. And then it's a good time to talk about contraception. We avoid systemic estrogen in our patients due to the increased risk of DVT, PE, and stroke. And we typically recommend something like a Mirena IUD. And then in terms of the infant, we have hemoglobinopathy screening, which happens now in all the states in the US, including Virginia, as Marcus went over. And then if the mother has been on chronic opioids, the baby should be monitored for neonatal abstinence syndrome. So in summary, sickle cell disease poses unique problems for both the mother and the baby, and women with sickle cell disease and their partners should be made aware of the increased risk of obstetric and fetal complications. Multidisciplinary care and close monitoring are essential for good outcomes, and more research is desperately needed to help both our women and their children. And September is Sickle Cell Disease Awareness Month. I'm sure you all know. Thank you for listening. Please find a blood drive in your area. We've got one next Saturday if you're looking for one. And thank you for listening.
Thank you, Dr. Davidson, and thank you, Marcus. If there are any questions for either of our speakers, you can feel free to put them in the chat, put them in the Q&A, or you can just come off mute and ask your question if you like. I don't see any current questions in the Q&A or the chat. If there are any, please share them.
Hey, Dr. Davidson, this is Shamari. Great presentation. I wish I would have heard it 3 years ago when I was pregnant with my daughter, because a lot of these things were missed when I was pregnant. I have I guess not as common. I don't have SS. I have S beta thal plus. And so a lot of these things were missed. So what can we do moving forward to make sure that patients are aware of these things, as well as being able to communicate with the providers to help them be aware of the some of the symptoms? Because again, like the blood pressure was missed with me. It was considered normal, but as you were stated, like a normal blood pressure for us is not necessarily the best outcome. So how can we make sure the patients are aware of this and somehow convey that information to the providers as well, so women with sickle cell disease that are pregnant can have better outcomes?
Yeah, I think it's a challenge for sure. I think that you know, having the support from VDH to have our center and centers around the Commonwealth is really important and helpful to have access to a place like that. So even if that's not necessarily where you go for your, day-to-day care, if you're able to go, even once a trimester or once a month to one of these centers where there is a team approach of people who are more familiar with these issues, specifically things like the blood pressure. When I have pregnant patients, I work really closely with the maternal fetal medicine team. I make sure all my patients are seen by the high risk group, because this is a high risk situation and we want people to do as well as they can. And it's, pregnancy can be successful with sickle cell disease, but we just really need to be really mindful of these issues. I think one of the things that I need to work on more, and I would encourage everyone to, is to make sure people have a reproductive life plan, where you've talked about some of these issues before someone gets pregnant, so that, the woman has education and has knowledge, so she can be her own advocate. Her family members can advocate for her as well. If they're not getting what they need, the more information people have, that's always better, I think. And sometimes it's hard because people are coming in with acute issues, they're having a pain crisis or this or that, and you don't take that time to really say, hey, today's visit, let's talk about, like, what is your game plan? I know you have a partner, are you planning a family? What can we do, to optimize your success? And that's something that I really want to focus more on with my younger patients, so it's not all a big surprise if they come in and they're pregnant. But it is challenging because I think there's a lot of just lack of knowledge out there about sickle cell disease and pregnancy and what you need to be looking out for. There's a really nice article, actually, Shamari, it's the American Society of Hematology puts out these review articles on lots of different topics in hematology, but one of the ones from earlier this year was How I Treat Sickle Cell Disease in Pregnancy. And it was a really nice practical review. So if anybody out there is a provider, that would be a great article to look at. It's very clinical. It's not super scientific. It's a really clinically based article.
And Dr. Davidson, I was going to ask, are there any simple tools for folks who are already diagnosed with sickle cell disease but are planning a pregnancy so that they can initiate the conversation with their doctor?
Yeah, there was a really nice, I think it was on the CDC website, and it was I'm just going to pull it up right now to see if I can find it. And they had preconception, during pregnancy, and delivery and postpartum. They had like patient sort of infographics and sort of handouts for patients. I'm pretty sure it was the CDC. Of course, now I can't find it, but when I was looking for graphics and things for this talk, I found it and I thought it was really useful. It kind of went over these things in layman's terms, the issues that I brought up in each section. I'll try to find it, Tiffany, and maybe I'll email it to you. And then if you wanted to email it out to the group, because I
Okay,
thought that was
absolutely.
a really good resource.
And I think that I found the article you mentioned.
The How I Treat.
Mhm.
Yeah. Oh yeah, here it is. Yes, it is. It is the CDC website, and it's in partnership with the Women and Girls Foundation for Blood Disorders, and then and the U.S. Department of Health and Human Services. So it's cdc.gov, and there are 3 different sort of fact sheets, and one's about what to know before you become pregnant, one is about during pregnancy, and then one is about postpartum care. And it's like steps for patients, how they can try to maintain their health during those periods. I can put this in the link in the chat.
Yeah, that would be great. Are there any other questions for Marcus or Dr. Davidson?
Great afternoon. This is not a question, but just a comment. I want to thank you both for your presentation. For me, I just think about how we educate the community as well around this particular topic. And then even thinking about from a policy level, working with the General Assembly. But I think the more, as you shared, Dr. Davidson, around education and community education, it's very important. And so you've given me another tool in my toolkit to help educate those I come into contact with across the state of Virginia. I work for the Institute for Public Health Innovation, but I think that there is a greater need for, as we collaborate on various topics around not just pregnancy, but family planning overall. And so I want to thank you both for the knowledge that you've shared. And thank you, Tiffany, for always having these webinars to educate. I know for myself, I gain greater knowledge about how do I formulate and think about ecosystems of people for healthier living and things of that nature. So I just want to thank you both for this presentation on today.
Thank you,
Thank you, Ms.
Kelly. Good to
Allen.
see you.
Yes, thank you. Thank you, Ms. Evans.
Any other questions or comments? All right. Well, I'd like to thank you again to our speakers, Dr. Davidson and Marcus. Thank you for your time. The webinar will be recorded. Well, it was recorded and will be added to the VNPC YouTube channel. So you can check it out there if you like to rewatch it or share it with anyone else. And I hope everyone has a really great day. Thank you.